Now, technically, if you look at the licensing laws and rules, an LSW gives you kind of authority, I guess, under supervision to do all of the assessment and diagnosis and psychotherapy. But if you don't want to necessarily stay at that level where you're always going to have supervision. You want to. That's what my advice is, to go ahead and get your master's degree so you can move up and then become an independent practitioner.
Yeah, I was planning on going out in the field a little bit and learning before I come back.
It's a good idea. But that's really unique about social work. It's the only, that I know of, behavioral health undergraduate degree you can actually get licensed with, which is fantastic. And that's why, I always say, I have a big private practice. We have several locations. And people will call and say, I want to see a psychologist. I happen to be a psychologist and a social worker. So the mischaracterization of what social work is that they're not therapists, they don't have as much experience, but it's actually the opposite. In fact, my social workers and counselors are typically the better clinicians on some levels, no offense to my psychology colleagues, because they've been in the trenches. Like, for example, you've done the casework, you've been in people's homes, you see how their functions operate, their systems operate, and when you see a patient sitting in front of you, and this patient starts telling you about his or her life or whatever, you're thinking, oh, I know exactly what that system looks like because I've seen it a million times. Whereas someone who doesn't have that experience would just be looking at them kind of in a unidirectional way, saying, they're thinking this way, they say they're feeling, but there are so many things that could be going on contributing to that need intervention. And that's where social workers really excel, because they have that very rich experience. So I really think it's a great idea to get some experience getting in those homes. Sometimes it's hard work. Well, a lot of times, all the times it's hard work, but it's so very valuable.
Yeah. Are there any strengths to studying psychology over social work?
It's very parallel in many regards. The major difference that you see between psychology and social worker counseling is psychologists, which really isn't the case anymore, kind of own the whole testing realm. And they're supposed to be better diagnosticians, and they're more, in the clinical world, they're more behavioral analysts. But now if you have competence, your licensing board allows you to do testing. If it ever came up, you would just have to demonstrate your competence, which would be, maybe you took a couple testing courses, you were trained by someone who is good at testing, who does testing. So, in our research-based, evidence-based, which we're going to get into world, we're encouraged to use objective measures, which is basically a psychological test. What used to be called a psychological test, now they're called objective measures. They're moving away from the term psychology because it's not really owned by psychology. Psychology is a big, broad topic. Psychologists are professionals in that area, but so are social workers and so are counselors. No one owns psychology. It's behavioral health, right? So they're on the clinical level, those are the major differences. But now, psychologists have, other areas in their profession that are different from social work. So what we have been able to see here is that theory informs what? Assessment and intervention, right? And does someone want to tell me how that works, like what you're being taught? How does a theory inform how you see a patient and how you provide an intervention? Does someone want to tell me? Anyway?
I would say it gives you a perspective to approach the client.
Okay. How does it look? Like, let's say I'm a client, I come in, and I tell you that I'm depressed. What might you do? I've got some other, how about you?
Well, it depends. With theory, I take personal environment theory, I'm going to focus on language that focus on the stuff that's happening around you, versus like cognitive theory, I'm focused on what's going on within your brain.
Okay.
Two theories that I really like and I find them very useful are the lifespan theory and intersectionality. So like when I talk to the youth, I'm more so focused on the lifespan theory, like what has happened throughout their life that's gotten them to the point where they are, or whether they're wanting to work on aggression. Some of them want coping skills because they experienced a traumatic loss, and just how is that all affecting them right now today?
So is any theory wrong?
No.
Is every theory right?
Mm-hmm.
Can theories be challenged?
Yes. Yeah.
Are they challenged? How do we do that?
Yes.
How do we challenge a theory?
Study.
Just challenge it, study it. Then we do some research. Right, okay. So I want to do a little exercise real quick and it's going to illustrate what a theory is and how we can kind of pick it apart. So if I were to tell you, let's say that 90% of you were carrying umbrellas today, and it is also extremely cloudy outside, looks like rain for sure. What would your theory be about why most people are carrying an umbrella?
Social learning theory.
No, just general.
But it's gonna
rain.
It's going to rain, right? So you're so eager to learn. I appreciate that.
That's my thing.
You're jumping ahead, but I like it. So the basic theory is people are carrying umbrellas because it's going to rain. People don't want to get wet. So the construct is, we're developing a construct, which is really an elaborate opinion or belief. I believe that people are carrying umbrellas because they don't like to get wet. Most people don't like to be wet, although I'm sure you'll find some who do. It's going to rain outside. That rain is going to get them wet, okay? So now let's think about it with this new information I'm going to get. On my way here, I noticed that the Student Center is giving away free umbrellas. What would you say to that?
not necessarily gonna rain, people just want umbrellas because it's free.
Right. Coincidental, right? Okay, so correlation is not causation. Okay, so there's new information. So this new information says, well, I can go over here, get a free umbrella today. I'm going to class, I might as well pick one up because it's free. So that just blows a hole in your theory, right? So how would we test that theory? About the rain or the free umbrellas, how would we test it?
Check the weather.
Individual.
You survey them? Yeah, right. So you would start by surveying them. Hey, why are you carrying an umbrella today? So you see the whole idea is you get very different, are likely to get very different answers. So your theory, although it makes great sense, it could very well be true, could also very well be wrong or be challenged by what we call a confounding variable. That confound is the fact that the Student Center is giving away umbrellas. So how do you think about this? Try to apply this to what you're doing clinically. So I come in again, okay, I tell you I'm depressed. What would you say?
What's making you feel that way?
Yeah, that's one question you could ask. How about anyone else?
She has a question.
Oh, I'm sorry. Anyone else?
No, that's totally how I
You're
felt.
sure?
Thank you for validating that.
I was just gonna say you could probably ask, about their life, like where do you live, what's been going on, tell me about your work, like what's been going on in your life, or.
Those are all excellent second questions. What should the first question be?
How are you?
Who said that?
Smart guy.
Yeah, you're on the right track, right? And why would you say that?
Because they're a person just like I'm a person. I just want to know how they're feeling.
Excellent. You're getting to know the person, not their symptoms. Okay, and we're going to talk a lot about this today. So an example is I come in, I tell you I'm depressed. Well, sometimes when we're trained as technicians, we want to go right for that symptom. We want to go right for that matching intervention. And we lose sight of this human being sitting right in front of us whom you have to get to know, right? Okay, so that's a good question. Those are the types of questions I ask. I never say, what brings you in today? Because I'm not a physician looking at your knee. I never ask, how can I help you? Because you're not at McDonald's, okay? What I ask is, or what I say is, come on in, tell me what's happening. What's going on today? How are things going? And you will have, there are many people in my position who would totally disagree with that because they learned from a book in their graduate class in 1970 that the first thing you ask is, hey, what brings you, how can I help you? How can I help you? Well, I've seen more patients walk out the door either literally that second or later on down the line. They can't build rapport by asking those types of questions. If your first encounter with the patient is, how can I help you? What's that feel like?
Because you don't know how that I can help me.
Right.
That's where they come in for.
You're all right. Everybody's right. Go
And
ahead.
it's like I feel like I'm just on a checklist at that point.
Exactly. Yes.
So I have a question. If a client comes in and tells you that they're depressed, and then you say, how are you? Wouldn't that just sound like you're not listening to them?
Well, you wouldn't. Your question would come after they tell you you're depressed. They don't even get a chance. What you do is you come on in, have a seat, and then if they tell you they're depressed, I will say, tell me more about that.
Okay.
Because I wouldn't say, how long has it been happening? Does it happen in this situation? Does it happen in this environment? Because you're going down a what?
A checklist.
A checklist, right, versus building rapport, saying, I want to know more about this experience you have. Because your depression, I promise you, will look very different from yours. And that's because there are many factors contributing to depression. Many, biological, environmental, the combination of both. You're familiar with the diathesis stress model? Does anyone know what that big fancy term means?
No.
Here's all it means. You can write this down if you want. It's not in the
What is it called?
Diathesis stress model. What's dia mean? Two. Okay, what's a thesis?
Theory.
Yes. What's stress? Can stress be internal and external?
Yes.
That's what it means. It means everybody's got a predisposition to something. You don't know if or when it's going to be triggered off until you experience that in your environment. That's all it is. So really what you can take from that is that a symptom or a behavior or a problem is attributable to both external and internal factors. Very broad, right? So why would you throw one type of intervention or one type of theory at that situation? Now, on the other hand, I don't think it's good to just try to pull an intervention from all different kinds of theories without being grounded in something. And why do you think that is? Why is it important to be grounded in something that resonates with you, that you
It
believe?
keeps you on track, focus.
It'll keep you
Focused.
authentic, keep you
Right.
authentic.
Keep you authentic. Excellent. Say more about that just real quickly.
Because then you can speak from what you know, what you've had experience with, so that you can be, empathetic
Right.
when you're speaking. as
Think
opposed
about it
to
like a house. Okay, so I know you've probably heard this analogy a million times, but if a house has a slab or a basement, then you build on top of that. It's got a pretty good, strong foundation. And if the windows fall out, you can replace those. Don't have to worry about the foundation. If the doors blow off, you don't have to worry about it. But if you have a house just built on gravel, you have no foundation. If the window falls off, maybe the whole rest of it does. So my point is, if you start using a couple interventions you're comfortable with, and the patient presents you with something different, your house is going to fall apart. You don't know what the heck to do. You can, when you're grounded in a theory or a theoretical orientation, it helps you kind of conceptualize a person in a way that makes some kind of sense. And from that, you can pull in different interventions based on what you're seeing. So with that, let's get started on the actual presentation, because I could talk about this for about 100 years. Okay, so just you all introduced yourself to me. This is who I am. I'm a psychologist, a social worker. Up until last month, I was a teacher, instructor for many years. I taught online at Argus University. They actually just closed down. It's a big, long story. But my focus was forensic psychology, clinical psychology, and human services. I actually helped write some of the programs and the courses. My areas of specialty are clinical, forensic, and health. Really, those all kind of overlap. I have a history of treating offenders and police officers and other public safety professionals, personnel. I've treated many, many mental health disorders, primarily focused on the heavy-duty personality disorders, substance abuse, because I worked primarily with offenders for the large part of my career, and I worked a lot in chronic pain. So how these things overlap is if you look at health psychology from a perspective of chronic pain, I used to treat police officers who were injured on the job. So then I ended up working in this big chronic pain clinic, and then did all kinds of forensic work or clinical work with the police officers, and then I did work with offenders, and then I did a formal postdoc in forensics. So that's briefly my background. And then I also founded in 2001 this agency called LA Behavioral Health Services, and that's what I was talking about earlier. We have several locations, and we treat pretty much a broad range of consumers. I don't, but we have therapists who address different areas. Yes?
What was it like working in forensics?
That's what I was gonna.
Well, it depends. Forensics is a big umbrella. I worked primarily with I did evaluation and treatment of offenders. I liked it. It's very interesting. Lots of people think that all offenders are personality disorders. Many, many are. But sometimes people just make bad decisions. Doesn't mean we excuse them, because I do in my therapy. I hold you accountable, but I'm going to help you if you can explore some of the things that help contribute to your situation, not use them as excuses, but kind of own them and move forward. I'm very traditionally trained psychoanalytically, but I also have lots of training in cognitive behavioral therapy from working in chronic pain management and with offenders. Because with offenders, a lot of times you're not getting people who have a lot of time to sit there and do tons of psychotherapy. You need to say, hey, your behaviors are this, the consequences are this. How do we help you understand that and make better decisions? Some will, some won't. It just depends, and that's when kind of personality factors might be involved. So it's very challenging, but equally rewarding. Just like anything worth having or anything that gives you gratification is often hard to get, and that's all right. Getting a master's degree is hard. It's a challenge, but it's worth it. Or getting a bachelor's degree, or anything. It's hard work, but if it were easy, then everybody would be doing it, right? Okay. So enough about me. So this is what we're going to look at today. We're going to define theory. We've already got off to a good start with that. We're going to look at theoretical perspectives in clinical work. And I'm very glad that you're all pretty familiar with some of the contemporary intervention models. That's good, like the cognitive, the behavioral, et cetera, because I wasn't sure coming in if you guys would have had exposure to that, but you have. And that's excellent. Makes my job easier. And we're going to talk about how to integrate theory and practice. Now, this is probably the most difficult, challenging thing that new professionals experience, because really you don't learn how to do clinical work from a book, from a great research article that Dr. Majesty had you read, right? You don't learn it from your friend telling you how to do it. How do you learn how to be a clinician? Experience. What does that mean? In what ways?
Actually working with the clients directly, going to their environments, and not just reading everything out of the article.
That's right. And you also get to learn a little bit about yourself. And I challenge you and implore you to reflect on yourself. Why did I feel this way? And in your supervision, what's going on? How did I feel when they said, why did I have this sense of this interesting reaction? A lot of people think, I've had supervisees who think that's kind of like taboo, we don't talk about that in supervision, but I say that's the first thing we talk about. That's what we need to know, where you're coming from, what your perspective is. You know, all the interventions and all that stuff come later. What's most important is learning who you are, how you function in these environments, and then from there you can build your kind of on your niche, I guess you could say. So then the last thing, and probably most important, we're going to talk about developing a theory-based identity. What do you guys think I mean by that? I'm going to give you these slides so you don't have to worry about it.
Thank you.
Anybody? Theory-based professional identity.
One that you feel grounded with, that like you can, maybe like your go-to, but not necessarily because you.
That's a pretty easy way to explain it. Yeah. Kind of like, you know, we all have a personal identity, right? Kind of one that we have and we feel, kind of one we have to present ourselves in something more formal, and then we have ourselves and then our ideal selves, right? Mm-hmm. So I'm asking you kind of think about your professional identity. Who are you going to be based on what you're drawn to, what theories, what perspectives, when you become a professional and you're actually out in the field and working? Does this all sound too heady and crazy, or what do you think?
Good. Give it to me.
Give it to you? Okay. So what is a theory? If you guys could just, let's create a definition of theory. A theory is a what?
Ideas, opinions.
Starts with ideas, opinions.
A guideline.
A guideline.
An ideology.
Ideology.
Like a proposed idea.
Proposed idea. Yeah.
Perspective.
A perspective. So interestingly, you guys are already doing what I would hope you do. You kind of start with a broad idea and you're narrowing it down to more educated, kind of thinking, kind of refined, but you haven't yet studied it or tested it. See, that's where we have to be careful with our conceptualizations, our theoretical perspectives and all that. So, but that's how theories start. They start with an idea. Same with research. Like, what's a hypothesis?
Educated.
Yes, exactly. We all learn them. God, I'm so refreshing to hear that you guys actually know it. Some students don't. But you guys do, that's good. Dr. Majesty, again, I have to congratulate you.
You got everything in this one class.
It's an educated guess. So a guess is not a bad thing. A guess comes from your experiences, right? And an educated guess comes from your experiences, you're putting ideas together. Like you're saying, you know what, I bet these, like, back there with the policy thing, if these kids aren't, acting a certain way, I bet if we had a policy to help them learn about their behaviors and have access to certain things or whatever, it would make them feel better, or they'd have better outcomes. It's a theory, and you could test that theory in a research project. You test that hypothesis. Good. You guys are getting it. Okay. So it's basically a set of ideas. Okay. So that they're conceptualized as a construct, and a construct really is kind of like a more refined idea. It isn't necessarily validated yet because you haven't necessarily researched it, but it's what we could probably call a hypothesis, right? An educated guess. But you're working under these assumptions because of your own experiences. And that is used then to make sense of information. So this is kind of I guess you could say, the trajectory of theory building. Okay? So here's an actual definition from two good researchers, Roemer and Van Ryzen. If you don't have their book, it's really excellent. I think everybody should have it. It's a logical, think about what terms jump out at you here. It's a logical description of how a particular corner or aspect of the world works. What terms jump out at you? Logical, particular, right? So logical, yes, because we want it to be organized and make sense. And then particular, because we're applying it to something specific, okay? And that's basically what you guys define theory very well. Here's a more kind of, I guess, formal definition of theory. Okay, so everything that we experience in our world can be explained by theory. So how about physical sciences, right? Theories in physical sciences, theories in psychology, theories in natural sciences. What ones are familiar to us, right? This guy? How about this guy, right? And then, of course, not the movie, not the show, the Big Bang. These are just examples. Theory dominates everything we do, dominates our world, who we are. Everything that we can think of has a theory attached to it. Even, for example, our umbrella theory, right? Everything's a theory. Your belief about something can be a theory. It's your theory. So theories can be tested, refuted, and supported. How does that happen? How do we test a theory? To have enough information to either support it or refute it.
With an experiment.
With an experiment.
Variables.
Right? Variables, experiment, okay, all this researchy stuff, okay? And that's exactly right. With the scientific method. So these terms, do they all look familiar to you? Research question, hypothesis, research design, methods, quantitative. What does all that mean? People are afraid of research, and it's sad. And it's sad because it's so fun and enriching and important to do. But what I've noticed in my many years of teaching is the fear is not necessarily of learning about new information or testing ideas. It's math, statistics. People think they have to be statisticians to do research. That could not be farther from the truth. All you do is you put those numbers into a computer program and it spits out data. All you have to know how to do is read and apply that data, okay? And it's very simple once you get the hang of it, okay? But it's important to be a good consumer of research, because if research is going to inform your practice, then you have to know what research says. How many of you read any research? Dr. Majesty says, read these 5 articles. How many go, now this is going to be in full honesty, how many go to the abstract and discussion just to get an idea? I've done it. Right. Why do you do that? You just want to know what it says. But what you're missing is all that good methodology. You're like, well, how did they come to this conclusion? I want to know about that. Were they looking for associations and then they did a weak design and looked for, and then they're also talking about looking at differences, although those can coexist? They didn't do it right, or why? This doesn't make sense to me. You should always question the methodology of everything you read. I don't care. You should question what I'm telling you right now. Like I tell my kids, no matter what someone tells you, question it. That's going to help you develop analytical thinking skills. Just because someone says it is so does not mean it is so. And I'm talking about even people who've developed theories that we're using today. Yes?
Well, isn't it in those types of details that you'll actually be able to find out as a clinician if it could apply to your client or not, or even if it has any kind of validity to it?
In the details of the abstract and discussion?
No,
Or
in the details, like when you're actually looking
the
at
methodology?
Right.
Of course. Yeah. Because you want to say, is this strong? I mean, just because it was accepted by, through the panel, the peer review panel, that doesn't mean that it cuts the mustard with you. Because what if that peer panel is a bunch of friends of this so-called self-proclaimed expert? It happens, question everything. I'm not saying that's the norm, but there are better journals than others. Some are more rigorous. Some peer review process are more rigorous than others. But you should always think about, when you read an article, what they're telling you, how they found this information out, and if it applies. 3 questions I ask my dissertation students are, what do you want to know? How are you going to find out? And how does it apply to your field? So what's the first question, Tab? What do you want to know? Anybody? That's going to help you develop your research questions, your hypotheses.
I don't.
The second is, how are you going to find out? What is that?
Research.
Methodology. Right, methodology. And how does it apply to your field? Well, that's why you're doing the research. We're an applied behavioral science field. So we're going to take this information, we're going to determine whether or not it's accurate or valid or whatever, and then we're going to apply it to working with our clients or patients. I say patients a lot. It's the way I'm trained, because I'm mental health. We always call our patients patients, and I'm very traditionally trained. Client is the more general term, because not everyone's doing necessarily psychotherapy, and even psychotherapy patients, clients now are called clients. So I will use that term interchangeably in case you're wondering. So I'm going to introduce you to, maybe I won't introduce you to, but these are some kind of jargony terms that are important for you to know as you develop your foundation for what we're talking about and for understanding research and theory. This is the broader umbrella of research. There's this thing called epistemology. It's a big, huge, fancy term, but it quite literally means the study of knowledge, the justifications for our beliefs beyond our own opinions. So what does that mean? The justifications for our beliefs beyond our own opinions. How do we come to that point? How do we justify our beliefs beyond our own opinions?
Are there facts that support your opinion?
Yep, and what is that? Research. Right.
Practical applications.
Right. Research, application, do these things align? And it's literally we're studying our knowledge, okay? How do we know something? We study it. The next big jargony term is called ontology, and this is the study of what exists. And you'll see as we talk a little bit more how these align with different kinds of research. So the study of what exists, how do we know something exists if we don't study it? These are kind of borrowed from philosophy too. So how do we know that that we're sitting in a room? Because you can observe it. How do we know everyone from practicum is here? Because we can observe that. But let me say this to you. Let's say you know everybody here is in practicum and that's why they're in this room. What if there's a student who's not in practicum and they came in the room at the wrong time, they just got the wrong room? Then you can observe that they're in here, they might be a practicum student, but that can be challenged because all you have to do is ask everyone if they're in practicum and one student will say no. So that's how easily a theory can be challenged or an idea can be challenged. If you want to read more about epistemology, I suggest you read this article, which is in the references. I'm going to give you that. It's a Stanford paper. It's kind of like a blog, but it's really interesting. It's got a really good history of it. So studying knowledge and searching for meaning and searching for what exists requires, again, here's that word, theoretical constructs. So what is a construct? Kind of a really parsed out idea that's not necessarily research. So we have to have this construct before we can engage in a study. So there are two types of approaches to research, generally speaking, deductive and inductive. And rather than get into a big discussion about what they are, I'm just going to tell you. Deductive is when we see things that are generally acceptable and we actually want to validate them, so we study it. And these are typically associated with quantitative studies because I want to see, like, this is cognitive therapy, for example, has been around for years. I want to see if it works with children between the ages of 9 and 11 who live in this area. So it's a bigger topic we can kind of pull out from that and we can study our own ideas and theories about that topic. Whereas inductive is where we develop new constructs from less information that we intend to want to generalize. So for example, this would fit along with a qualitative study because in qualitative studies, they're typically kind of groundbreaking. There's not a lot of information. Qualitative, I would actually maybe want to interview people about their experiences, and from that information, I'll pull out themes that I could then later maybe study quantitatively. So that's just kind of very generally speaking how these terms all fit into research and how they all fit into theory building and theory testing. Because what we're doing every time we engage with a patient is we're using a theory or theories to understand them and then to provide interventions to them. Okay? So remember our umbrella exercise, okay? What did we know? How did we know people were carrying umbrellas? How did
see them?
We observed them, right? We actually saw them with our own eyes. Hey, these people are carrying umbrellas. Well, that's kind of like an observational research activity, right? So we were able to observe it. Why did we believe it was because it was cloudy outside?
We just assumed that.
We assumed that based on what?
Our association with when it rains.
Yes.
Typically cloudy outside.
Because that's what we've learned and makes sense, right? It makes sense that you carry an umbrella when it rains. Right. That was our construct, okay? Our construct wasn't necessarily wrong, it was just not fully right. There were other reasons, I should say, right? People use umbrellas when it rains because they don't want to get wet. Clouds are associated with rain, therefore people were carrying umbrellas on a cloudy day, right? Seems like A plus B equals C, right? But it does not always. A plus B does not always equal C. So then we're able to test our theory or construct with this new information, and we found, without even really testing, that there might be a different reason that people are carrying umbrellas. And that was because, remember? Right. I think we got past that tough part. So applying the scientific method to clinical practice looks a little bit something like this. Now, when I say professional community, I mean people who've been in the field, people who might be researchers, people who might sit on those peer review panels for articles. A theory is presented to them, and these theorists, they test the theory, okay, and then if it passes, then the professional community accepts the theory, and then we put that thing right into practice, okay? That's typically how it goes. Of course, in between there, you'll have the challenges, you'll have the refutations, you have the supporters, this camp likes it, this camp doesn't, whatever. But in any case, it passes the scientific test, so we start to implement it into practice. So this pragmatic application of theory has been going on since the Enlightenment period. Have you guys learned about the Enlightenment period, what that is?
We're not in class, but it's
What is it?
Basically, is a period where in like England they were like putting in new art, new ideas, new ways to express
Yeah,
themselves.
the whole idea of realism, empiricism, reason, and logic came into play. But because before then, what fueled people, or what supported people's beliefs, or what were they based on? Religion. What else? Mythology, right? Supernatural stuff. So people started eventually saying, you know what, this doesn't make sense. I think that there are more explanations for our own existence. So let's try to figure that out. So that that started happening in the Age of Enlightenment. And then from that, the positivists and post-positivists emerged. You guys know what those are? What's a positivist? I have a feeling you learned this. Think about it in terms of the Enlightenment period. Go ahead.
It's like a person who just sees things for like the best case scenario, right? Someone who.
No, that's a different use of the term positive. And it's really not a person, it's kind of like a movement. You can be a positivist or post-positive. All it means is you're a realist. You base your experience on observations. Like, I believe it when I see it. I believe people are carrying umbrellas because I actually saw it happen, okay? But a post-positivist would say, I do believe in your observation, that people are carrying umbrellas because I observed it. But the reason might not be exactly what you think it is. So there is some fallibility there, and that's what the post-positivists would say. We need to think about that fallibility and look into it. So when we do a research study, for example, we have a hypothesis, which is an educated guess. Do we try to prove that hypothesis in our studies?
Yeah.
No. Here's what we
try to prove it wrong.
Right. We try to reject the opposite of your hypothesis. It's very weird how it's organized, but there's a reason for that. So you have a null hypothesis, which says there is no association between A and B. Your alternative hypothesis, which you actually believe, there is an association between A and B. But what we want to do is reject the null hypothesis, because what we're saying there is we reject that, but we are willing to accept that there is a certain amount of error. So for example, you say, we're looking for the chance that our change could be due to chance rather than it is our theory or our intervention. So if, for example, you've heard of a p-value, p05, all that means is we're willing to accept a 5% chance that our results are due to chance rather than our experiment or our intervention. And that's all that means. And if it is below 5%, that means, there's less than a 5% chance that it's due to chance. So we would reject that null hypothesis. So the idea is you're not trying to prove what you believe. You're trying to prove that there are kinks in what you believe, okay? And you're willing to accept a little bit of error there. That's all that means. That's what the post-positivists would want to do. They want to look at the fallibility of your proposed theory. And this basically, we already talked about this. It's the time they moved away from supernatural and religious explanations for how the world works. And this call for science really took off around that time, okay? And then the response was the scientific method that we actually use today. Okay, it's evolved over time. How do you think it's evolved over time? From the Enlightenment era to now. How do you think the empirical method? Trial and error. What else?
It's become more scientific, more precise.
Yeah, more math procedures have evolved, more different types of analyses. In the past 15, 20 years, different types of analyses have emerged. Yeah. Technology has helped a lot, yeah. How long would it take to do a paper and pencil calculation of some big, huge number? Now you just put it in the computer and it's like, there it is. So before technology, we didn't have the capability to do major, huge analyses. And it's adopted by social sciences, okay, and applied social sciences. What are the difference between social sciences and applied social sciences?
Social science is just the study, the applied social science is actually how you use it.
It's basically right, yeah. Sociology is kind of like knowing just to know science. Social work, applied social work, is knowing that information and applying it to your actual work, generally speaking. And now it's expected in the behavioral and social sciences that we use the scientific method. And a term you're going to hear a lot with respect to interventions is this. Now, what does that mean? You see how it all funnels down to this? Right, okay. Now, I'm not knocking evidence-based. In fact, I think you should use it a lot to inform your practice. But I am going to ask you to look at things a little differently. So it's basically the language that we use, and it wants research to inform your practice, okay? It doesn't mean when you see a patient who comes in and says, I'm depressed, that you run to Dr. Majesti's articles and say, what is depression? This person must be doing A, B, I'm not, I'm just saying it's probably not A, B, and C, so I have to do this intervention, and then they're going to be fixed. Because you'll be disappointed, trust me. So basically what this means in translation is, there's a symptom that your patient, we talked about this, this person presents with a symptom that's conceptualized by a theory of psychopathology, right? Many theories of psychopathology, cognitive, behavioral, family systems, whatever, psychodynamic, you can run down the gamut. That theory then, of course, is the theory of depression, for example. This person might have distorted beliefs about him or herself, the world or others. Whose theory is that? You're studying cognitive theory, whose theory is that? The father of cognitive theory, right there. No? Nope. Aaron Beck. Okay. Cognitive theory is relatively new, right? So Aaron Beck started it all, but the interesting thing is there are so many permutations because of all these new therapists and new and applications of cognitive behavioral therapy. It's interesting, as it's occurring to me now, that it's sad that people don't even know who the founder of cognitive therapy was, but they're using it all the time. That shows you how much it's been researched and diluted and turned into all these different acronyms. So, it's good to know the foundation of what you're doing and the author of that. You should read, if you haven't, you should read one of Aaron Beck's or his daughter's books on cognitive therapy. They're very excellent. And you might find that you're practicing cognitive therapy very differently from how he intended it to be practiced. But that's a separate discussion that we're not going to get into here. So theory-based intervention then, okay, so now we know the theory of pathology and symptoms. The next thing we do is we pull out of this another therapy thing I really don't like, toolbox of interventions. So what's missing in that whole equation? The symptom, the theory about the symptom, and then the intervention based on the theory. What's missing?
Self.
The subject.
Humanity.
Knowing about the subject.
Good. You're all right, okay? The first thing is this. Think about it. You have a human being sitting across from you. A human being, right? Did you get into social work to throw interventions at people or to work with human beings?
No.
Right. What else is missing? Consideration of dynamics. What is that? What is something? What is that?
What is causing that person to be that way?
Sorry.
Right.
Sorry.
You're both right. So
Intersectionality, yeah. They're a whole multi-systemic.
everything interacting, right? There are many systems in this room right now, right? You have a family, I have a family, we're interacting, right? There are people out there, there's a Starbucks downstairs. All these systems are always working together, okay? So if you just look at people from a purely evidence-based perspective based on interventions, you might miss the humanness of the people you're actually working with. The next thing that's missing there, I see this a lot. Now I know it gets lip service and word service in your books, but in my experience, it does not resonate with novice therapists because they're so focused on the interventions.
Mm-hmm.
What is the importance of building rapport? What is rapport to begin with?
Well, building rapport is like establishing the entire helping relationship. If you're not going to rapport with your clients, they're not going to even try to listen to or come back.
That's right.
That's like how I was saying, how I go outside with the families that sit in the waiting room and actually sit there and talk with them to make them feel welcome and comfortable, where they can open up more.
You're validating their humanness, probably, right?
Yes.
And you're establishing a connection. The way I'm trained, regardless of the heady interventions and all of the theory or all of the ideas about development and pathology, the vehicle of change is the relationship, period, okay? And so let's talk about, real quickly, the concept of transference and countertransference. Have you heard about that before? Do you know what that is? Transference and countertransference. So transference basically is when a patient starts treating you, like projecting onto you experiences they've had with other people in your role, like an adult figure. The most common is the parental transference. So let's say that I'm trying to do this cognitive intervention I read about in this cool article that I knew is excellent, cutting edge stuff, and this patient of mine just will not do it. I start to get frustrated, I start to feel helpless, I start to feel incompetent, when all along, two things could be happening, or many things, but let's look at two. One could be, you remind them of their mean mother. You think they're going to listen to you? They're engaging in a human phenomenon you're going to learn in psychology called reactance, and all that is when you tell someone to do something, they do the exact opposite, okay? Another thing that might be happening is, you might be engaging in a countertransference, which is your reaction to their transference. So if they're engaging in a dynamic with you that's ingratiation, they don't appreciate anything, and you try to give this to them and give it to them, you're getting frustrated, helpless, and angry, and that's how everyone around that person feels. I promise you that. So that's why it's important not to just go for the intervention, but to get to know the person, get to know the dynamics, get to know all of the factors affecting functioning. Then, and only then, can you start to work with a patient or a client, okay? When I see a patient, the first thing I do is, like I said, tell me what's happening. Well, I just shut my mouth for 5 minutes unless I need to query. I want to build that, tell me what's happening. I want you to know that you can tell me what's happening. We're in this together, okay? I'm going to help you figure this stuff out, make sense of it so you can process it better, feel better, whatever, make better decisions, whatever your goal is. Whereas if you come in and I say to you, how can I help you? Tell me exactly what you're thinking. How long has this been going on? What are we going to do next? What are your goals exactly? You're not doing good work. And if anyone who tells you you are, tell them that I said they're not and then call me. Because you're just not. So is the use of evidence-based practices, approaches, et cetera, a misuse of science? What do you think?
No.
I don't think it is. But let's play this game just for fun, okay? I'm going to say there's a yes camp and there's a no camp, okay? So yes, if we do believe it's a misuse of science, the argument might be that human beings are more than their pathology. We could all agree on that, right?
Yes.
Of course they are. In the no camp, you might say, hey, we have to focus on those symptoms because that's what's most important, right? That's why they're coming in. That's what the research says. These are the interventions we use. So you might say in the yes camp that the foundation of clinical work is the relationship. And if you said that, you'd all be right. So it makes sense that if you're over here, yeah, I want to reject that whole evidence-based thing, okay? The no camp might be the client's presentation warrants these interventions, which could also be true, right? So could all of this be true so far? Do you have to be in one or the other camp?
No.
No. And in fact, let's just do the remaining two. It's a dynamic. Factors can't be reduced to measurable units, and all components of human functioning are measurable. So there's truth in both of these. So what's happening now in the therapy world is what I believe, I don't think I coined the term, but I call it reductionism. And what that means is, if you've ever written a treatment plan or a service plan, you'll know what I mean. You have to be able to break down goals and objectives into measurable units, right? So think about that. How do you measure someone feeling better? How do you measure someone gaining insight? Is that possible?
You have to ask them questions, but you start at the beginning of like activities and certain things they do and do not do, and then after a few weeks you check back in and see.
So you're on the right track. So you can't really measure someone's feeling of insight. It's kind of an abstract concept, but you can measure elements of that. So some things can be measured. And here's a good way to look at it. When I was audited, we were certified by the state for substance abuse, and we're going to be hopefully here soon for mental health. The auditor, to me, made a very good point when she said, think about a measurable objective like this. So I want to stop drinking coffee. Let's say that. I don't, but let's just say I do not. Let's be very clear. Let's say I did want to stop drinking coffee. Well, how could I like break that down into measurable objectives? So my goal is I want to stop drinking coffee, or I want to decrease my coffee use.
Figure how much you drink.
What would be measurable? Yeah, I want to figure out how much you drink, whatever. What else? What's
how
measurable?
much you're spending on coffee?
How much I'm spending. So a measurable objective would be, I'm going to go to Starbucks 3 fewer times per week, and I'm going to spend this much less in money on coffee. That's very measurable. But to actually try to measure, I want to stop drinking coffee is kind of difficult, right?
Right.
So you can always break things down into measurable units, but sometimes people's problems are more complex than that. So the challenge is trying to break things down into small measurable units. And sometimes you just learn how to play the game. It's awful to say, but it happens all the time. But you don't have to play a game. You can actually validly measure what it is you're trying to measure. So don't get into the game thing, because then you're just trying to, then you're focused on the paperwork. Don't ever treat the paperwork. We want to treat the patient or the client. And that's what we call it in our field now. There's so much heavy paperwork burden, and we call it treating the paperwork. It just leaves no time, less time to see the patient or client. Yeah, does someone have a question?
What do you mean by playing the game?
Well, the game of, if you don't write this in your notes, we're not going to pay you, or we're going to take money back, or you're going to lose your certification because you're not documenting your goals right. I mean, it's this thing that's been going on for years with Medicaid, but now it's happening with commercial insurance and all that. So you just have to be conscientious about that. And the way to do it is to become good at it. Don't fear it. Don't let it beat you. So to become good at it. Okay, like the coffee example that the ODATIS or ODMH auditor gave, or OMAS it's called now, gave me. It's very excellent. I use that example all the time. I should credit her. Next time I see her, I'll tell her that I use that example. So it's good to blend ideas from both schools of thought, right? Who can argue with this? Human beings are more than their pathology, but it's important to focus on their symptoms and their humanness in every interaction you have with them, right? The relationship facilitates interventions. Of course, we know that. And dynamics can't be reduced to measurable units, but like we just talked about, some important behaviors can be reduced to a measurable unit. Yes.
So instead of doing the measurable goals, what is it that you're suggesting instead?
Well, I'm suggesting that you do the measurable goals, but don't let those drive the intervention. So, if someone comes in and they say, I feel terrible, or I want to work on this, you can't measure everything. Like, for example, it's hard to measure insight. So you have to get, a measurement means it's either time bound or number percentage bound. Mm-hmm. So what I can say is, here's a goal more based on insight. John Smith is going to gain 50% increase in insight into his dynamic factors causing depression. Well, I mean, that's a goal I would write, but how do you know it's like real? It's hard to measure. It's very subjective. The patient's going to tell you, but it's still acceptable. A different goal would be, John is going to decrease arguing with his wife to 2 times per week versus 3 times per week. You see, it's very different, and you're going to actually have to ask him to, when he feels like arguing, use the insight he's gained and walk away. Then the next day, maybe you can argue a little bit. It's kind of like a paradoxical intervention. So when you think about how to measure that, you have to be very creative. But if you look at all these treatment planner books, they're not creative. They just think you're using that evidence-based approach, and everybody's gonna change in this idyllic, measurable way, and all this stuff. And it just, we're finding it doesn't work. Yeah.
Are action plans measurable?
Yeah, that's the same thing. An action plan, I'm assuming in your context, is a treatment plan. And I shouldn't say that those interventions don't work. We're finding that people are moving back to depth psychological approaches. They're more interested in that stuff. And if you notice, some of the newer so-called evidence-based practices are heavily founded in depth psychology, like Rogerian, motivational interviewing. Those are types, and even narrative therapy to some extent. You can get measurable goals from that, but it's very kind of like traditional in terms of getting at people's feelings, thoughts, and their narrative about themselves and how they actually can change that. And we'll talk about that. But all I'm saying is use a healthy blend of both. Don't jump way over into just everything's goals and measurable. You have to do that, but don't let that be necessarily just the work that you do, because you end up, like I said, treating the paperwork instead of the patient. Yeah.
So, like what you said about measuring, do you use that in your practice, as an intervention, with the coffee time, measuring how much time you spend?
Yes, that could be a behavioral intervention, right?
Because I don't, me personally, if I tell myself I'm going to limit something, I don't really, like coffee drinking, for example, I typically end up doing it more.
So that's a perfect focus for the treatment then. The goal is one thing, but if you know that a barrier for you is when I tell myself I don't want to do something, I want to do it more, that's what we're going to work on. You can still measure the goal as a result of that, but that's actually excellent, because that's what I want to focus. Well, why is that? Let's talk more about that.
How would you work on that?
Oh, that's a whole separate topic. I mean, depends on what theoretical approach you use and what resonates with you. How I would do it could be very different from how you would do it. So I'm happy to come back and talk more about yours if you guys want, but that's up to you. But yeah, I appreciate the question. It tells me you're thinking about this and you want to learn this stuff, which is excellent.